Okay, good night, everybody. Can you hear me clearly?
Yes.
Yes, teacher.
Perfect. I'm sharing the screen. Can you watch the screen?
Yes, teacher.
Of course.
Okay. Let's make it wider. Let's start. I think it's enough time we are waiting for. Well, tonight we have an objective, a very nice topic to talk about. And in general lines, we can say it's a general view. Is very important, this part, for everybody in medical or in health areas, in this kind of job. Taking a history. In this presentation, we are going to check lots of questions, ways to get to collect the information, how to make the correct question, and of course, how to consider lots of these details, okay? Or how to show this information while talking to a supervisor, to a superior one. That's why when we consider a full case history, we take in account all of these points: personal details, the presenting complaint or the main complaint, the past medical history, the drug history, family history, social and personal history. We must consider patient ideas, concerns, and expectations, and a review of systems. Well, just a very, very fast review, because all about system was taken in account during the module 1. Maybe how to make a specific question could be important, but just a detail. Well, we have the first point, the personal details. So when we're talking about personal details, we considered all the information that is about my patient. I mean, the full name, the location, health insurance, phone number, all these details, okay? And normally, this information is collected or recorded by a nurse or administrative staff before the doctor sees them. I mean, you remember we were talking about the clerk. The clerk is that person who takes this information and organizes all the documentation. It's this lady in this case. She collects everything, takes the main complaint as a note, and according to that, they make the triage. According to the emergency system, right? And according to the triage, we decide who gets into faster to be in the doctor appointment or in the doctor attention, I mean. And of course, we have the chance to continue to get in contact with the patient as a consulting room. And we can check as doctors all of these details again in order to ensure how it's going on. We have to be so clear about occupation, marital status, because of loyal situations. Occupation, of course, because we can make the score of risk while job, about the kind of job that the patient has, about the occupation, right? And the marital status, because a loyal situation. It's not the same a single one than a married one. Why not? Because when you get married, your couple is the one who has the loyal responsibility over you. When you're single, could be your parents, your siblings, your relatives. Well, it's according to the situation, which family member is closer to you, and then is the one who has the capability to take loyal decisions in medical areas, in medical situations. Friends, cousins, well, not so close people is not admitted to take that kind of decisions. That's why we have specific questions to make, just as an example, because you have the chance to be creative. You have the opportunity, of course, to find another way to make the same question. That's why. To find out or to check a patient's occupation, we as doctors, as health providers, we can say, do you work? Or what do you do for a living? Okay, these questions are going exactly to the point with the information we really need. And we might get similar answers, 3 options. They may respond, no, I'm unemployed, or maybe I'm out of work, using phrasal verbs, okay? Or maybe they can say, no, I'm retired, I'm a pensioner, okay? Or they could say, yes, I work for a bank, maybe. I work in a factory. So you can see, you can make a fast overview about the health risk. Talking about the marital status, we as doctors, we can say, do you have a partner? When we say partner, we are being so general in words, I mean. Nowadays, it's possible to get in trouble with someone who has a different preference, we can say. Saying partner is without gender. That's why it's better than asking, do you have a wife? Do you have a husband? And it's not a correct way to ask that. It's better to say, do you have a partner? Or maybe, do you have a spouse? Or something like that, okay? And patients can say, they can respond in this way. The first one, no, I'm single, I'm separated, I'm divorced. You consider these 3 ways of talking, right? These possible answers when the patient is alone. Another way to receive the answer. I live with my partner. I live with my spouse. I live with my husband, or I live with my wife. Well, we all know we have to be so open-minded about these new tendencies. And well, that's correct. We can get this answer, yes, I'm married. Or maybe we can receive this, no, I'm a widow. No, I'm a widower. No, I'm divorced. Or maybe the other way, my spouse passed away last year. Okay, so we have 5 ways to receive the similar answer about the marital status. If they are alone, we must ask who is coming with you. In that way, we can get in contact with the relative, with the family member. Let's consider these specific words. Right. A spouse can be wife or husband. It's without gender. That's why I was telling you that you can make in this question, do you have a partner or do you have a spouse? Without gender, for not being offensive to anybody. At this point nowadays, we really don't know. Widow is a woman whose husband is no longer living. Widower is a man whose wife is no longer living. To avoid saying that someone is dead, patients usually say that person has passed away. That's the phrasal verb. Widow, a woman whose husband passed away. Widower, a man whose wife has passed away. So let's consider this. When we receive a patient, well, when we consider making research, reading the causes of attention, of medical attention in emergencies and consulting rooms, we realize that pain is the first cause of going to the doctor. Pain is a very important symptom that patient is telling us, okay? When we talk about pain, we must consider that it has societies that are prepared for doing the evaluation of this. Please give me a second. I'm sorry, my baby was crying. I went to pick her up in order to stay with me. Well, patience. Okay, getting back to the point. When talking about pain, I was telling you that is the most important case. The first one, while going to the doctor. Lots of societies where we are focused on attending this situation, on giving this assistance, this medical assistance specifically. But at this point, we have to consider this. While making the case notes, while recording the information of pain of the patient, from the patient. As I was telling yesterday during the workshop, we use abbreviations, lots of abbreviations, like the ones that are here in the box. In this case, we are talking about the presenting complaint or the main complaint, the most important symptom. When we take in account the right-sided temporal headache, severe and throbbing. As you can see, they are just going to the point. And then we say how time it lasts to 24 to 48 hours. I mean, you can see abbreviations going to the point, maybe without connectors, while writing down, because it has to be as brief as we can and make it as fast as you can, okay? Then let's go ahead. When we talk about pain, we have two important societies, the IASP, the International Association for the Study of Pain. It's a worldwide association, and the pain paper, we can say, it's a paper when you get the review about the actual studies and knowledge about pain. And we have some definitions here that is for open our vocabulary. The IF says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. In contrast of pain, the pain paper, pain is a distressing experience. So you can see there are different ways to make the definition of pain. Associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. They take into account many personal ways or many spheres about our life and this definition, right? So, for example, talking about pain, we must ask about some symptoms. For headaches, we as doctors would expect to establish most of the features below. I mean, similar questions can be used in other forms of pain. The specific features we are going to check are all of these ones in this chart. Very important one. Please keep on reading this, practice on these questions, because this chart is going to be in the final test. The features we might take into account are the main site, radiation, character, precipitating factors, time of onset, time of resolution, frequency, aggravating factors, relieving factors, associated features, duration, and severity. All of these features have a question, a typical question. This is just a suggestion. You have the chance to be creative and make the same question in other words, in another way. It's your choice. It's the way you prepare to do it, but the meaning has to go to the same point. For example, talking about the time of onset, when do they start? When the pain started? Or, I don't know, something like that. Okay, you can change it. About the duration, for example, how long do they last? So taking into account this chart, please read all of them, practice on them. It's going to be easier to consider the correct ways to ask for this specific information. We all know we have the chance to make the pain evaluation, to rate the pain, to give a score, and according to the score, we can get the probable meaning, how it's going on, right? This comparative pain scale chart, the pain assessment tool, is the common one. We all had the chance, I think, to watch this and sometimes, and we had the chance to practice on this information. We have the feelings here described for being organized. So read this, practice on this. But we have to be clear, this is not the only one pain assessment tool. We have all of these ones. The OPQRST, the quiz taped, the Socrates, the pain risk factors assessment. This is a website, this one, when you can check all of them, the definition, when to use this pain scale or this assessment tool. And according to that, you can choose which one is the best in each case. It's not for everybody or every scale. This one with faces is great in adults because we can make the definition, we can understand the meaning of this. If you show it to a kid, you may have a mistake. For kids, there is another pain assessment scales. For pediatrics, I mean, are all of them. Since newborns, neonatal pain, you have the flag, faces, legs, activity, crying, and consolability. So you have the Children's Hospital for Eastern Ontario pain scale. The CHIOPS is very specific from this hospital, but the features, the topics they are taking into account are very useful at this point. For adults, we have all of these ones in order to consider again. You can see there is not just one. I'm gonna send the link to the page, to the website, and then you have the chance to review all of this. And according to that, it's possible to make it. It's possible to maybe to catch extra information that is going to organize. This study from the American Journal of Emergency Medicine was done in 2018 in order to show that we as doctors in the emergency room certainly don't choose the correct pain scale assessment tool. We take the one we are familiarized, we get it as an idea, we personalize this rate, and according to that, we give the score, and it's not correct. Okay, so in this study, a systematic review of pain scales in adults, which to use, is referring to us about which one is the best in the moment we are getting in touch with our patient. No matter with low pain, a critical patient, and unconscious patient, you have the chance to evaluate pain in all of them. That's why I'm showing you a list of pain assessment tools. When we talk about the description of pain, we have all of these ways, this patient description, okay? These specific words. I tell you by experience. When I was working with travelers, Americans, and well, people, natives in English, they use these words to describe pain. But sometimes I didn't understand because they are not common questions, common words, I mean. So without any trouble, I had to be clear and ask for the meaning and tell tell them, please tell me in another words, in another way, because I don't understand that word. And they made similar explanations of the situations. For example, gnawing is beating. When a bug is beating, it's the same sensation, the same feeling. Stabbing, like a knife, when you feel the cut of knife, that kind of pain. Or stinging is sharp, burning, like an insect sting. So these specific words are for reading, for practicing, and again, this chart is going to be into the final test. So study on this, practice on this, and of course they are not the only ones we get. We have list and list, but this is the chart that is going to be in the test. So take this one in count. There is a list that is giving us more pain descriptors, but just as extra information. Consider this, look at the meanings, and according to that, making the contrast with this chart, you are going to reach your own vocabulary in order to talk better, I think. So, for example, shouting is not there, soreness is not in the chart, but take it in count. For example, colicky and intermittent pain, which varies in intensity, comes and goes in waves. As you can see, lots of them are the same that in Spanish, just the translation, okay? Take it in count, practice on this, and well, you know. When we consider the difference between acute pain and chronic pain, we must take in count this. We must realize that according if it's acute or chronic, the treatment is going to change, even the evolution, right? About acute pain comes on suddenly, usually the result of injury, surgery, or something similar, lasts 6 months or less, relief when cause is treated. Easy. Acute has a treatment. Chronic comes on gradually, usually the result of conditions that are difficult to treat or to diagnose, last more than 6 months. That's the point of make the difference, the duration in time. 6 months is the topic, and difficult to find lasting relief. There is no way to get a cure. Well, it's so hard to do it. Okay. About the drug history, well, we have this text, and we have the chance to check some vocabulary in black and words. These specific expressions and words, of course, are important for checking our vocabulary. For example, talking about medication, it's essential to obtain full details of all the drugs and medication taken by the patient. We all know about it. We have to ask for about it. Not infrequently, patients forget to mention or forget the name of drugs they take. Very common situation, right? Some may be over-the-counter remedies unknown to the general practitioner. The significance of others, such as herbal remedies or laxatives, may not be appreciated by the patient, so they don't take it in account as medication, but we have to ask for this. It's necessary to determine the precise identity of the drug and dose used, the frequency of administration, and the patient's complaints or lack of it. If we don't do it, we can make a mistake while talking about medication, or maybe sending a new one. We can repeat the same drug, maybe. It is important to ask about known drug allergies or suspect drug reactions, and to record the information on the front of the notes to be obvious to any doctor seeing the patient. That's why we usually had experience to label the clinical history in the front. in order to show that the patient has a drug allergy or a drug reaction with a specific medication, right? Failure to ask the question or to record the answer properly may be lethal. So, it's very, very important to do it. So never forget it. And as usually nurses do it, use a type, write down allergy to, and then the name of the medication. Usually, not the commercial name, the chemical name. Questions that we can make for finding out the drug history are the next ones. Are you taking any medication at the moment? Which tablets do you take? Do you use any over-the-counter remedies or herbal or homeopathic medicines? Sometimes we forget to ask about homeopathic medicines. They are sold by free, so we should ask about them. About the frequency of administration. How many times a day do you take that pill, for example? About the compliance, do you always remember to take it? It's very common in elderly to forget the doses, and in the next time they try to take it doubled, or maybe take 2 pills for correcting the dosage. And of course, it's wrong. We have to be clear on this. About side effects and allergies, we can say, do you get any side effects? Do you know if you're allergic to any drug? If the answer is yes, we must ask for this. What symptoms do you get after taking it? Okay, some patients could say yes because they want to be in the focus of attention, and they certainly don't know what's going on with this. They consider that all the medication make the same drug reaction or the same allergy, but we know actually that it's not the way it works. That's why we have to ask for it, and then following that information, we have the chance to check if it's true or not. About family history, we must consider the age, the health or cause of death of parents, siblings, spouse, and children. Considering all of these details, we can make the family tree, maybe if it's necessary, and get an idea how healthy is that family. Or how healthy is my patient according to his family history. To find out about family history, we can ask, do you have any brothers and sisters? Do you have siblings? Maybe we can say, how old was he when he died or when he passed away? Could be better, passed away sounds better, and it's not so direct. Do you have any children? Do you know the cause of death? What did he die of? We have those options. Are all your close relatives alive? Are your parents alive and well? Does anyone in your family have a serious illness or disease? Is anyone taking regular medication? So consider. Just suggestions. If you have different questions to make or to prepare going to the same objective, do it. You are free for doing this. We are not enclosed on that. This is the only one question we have to make. The same, if there are more questions that you think are important, make them. It's important. It's, of course, necessary to do it. The social and personal history. Well, it's important because we have to record the relevant information about occupation, housing, personal habits, I mean recreation, physical exercise, alcohol and tobacco. And in the case of children, school and family relationships. Okay. The most common questions about taking the social and personal history are the ones in this list. What kind of house do you live in? I mean, are you paying rent? Are you the owner? I don't know. Are you taking care of house? Like a housekeeper, maybe? Why it's important? Because housing is a cause of full stress in any person. If you don't have where to live, or maybe the way that now USA is going on with lots of people that is without house, they're living in their cars, it's a stressful way of living. It's a risk factor in health. And it's worse if you have children, you are without a house, you are without enough money to rent a place in order for living properly, right? Another question, do you live alone? We know living alone is a risk factor about depression and lots of situations that nowadays are so supported. Maybe taking a pet changes the situation about living alone, that it's not the same a pet that someone, that a person next to you. Another question, who shares your home with you? Is that a relative? Is a friend? Is a stranger? No, it's right. How old are your children? Chronological periods, right? Are any of them at nursery or school? Nursery is that place when you leave your babies and your toddlers for being taken care of in order to stay there safely while you are working. It's usually for a couple of hours, but according to your job, could be more time. Then we can ask, what's your occupation? Or do you have any problems at work? Taking into account this information, it's possible to understand how stressed this patient is living on. More questions. Do you have any financial problems? So hard to ask, so hard to answer, but it's necessary to know. Do you have any hobbies or interests? Okay. What about exercise? Do you smoke? If the answer is yes, how many a day or how many cigarettes per day? We can ask the patient, have you tried giving up? Another question, what about alcohol? It's wine, beer, or spirits. When we say spirits, we are talking about rum, I don't know, Fernet, or everything different from wine and beer. Okay. Another question, can you give up alcohol when you want? So hard to answer, hard to ask, but necessarily to know, right? How much do you drink in a week? Sometimes patients don't realize they have a trouble with alcoholism, and while asking for, they notice that something is out of hands. They cannot handle the situation in the way they certainly think they do. That's why we should do this. What's the most you would drink in a week? Are you aware of any difference in your alcohol consumption over the past 5 years? I mean, are changes from the past 5 years to now about your alcohol consumption? Taking this into account, well, patients realize the situation is going bad and they consider it's important. Right? Okay. Talking about the reviewing systems, Well, we know it's our job, finally. We have the way to make it. We have the medical way to do it, the organized procedure to make this. So once you know the main reason why the patient wants the medical attention, the medical assistance, it's sensible to ask about the systems to determine the patient's general state of health and to check for any additional problems. Maybe the main complaint is just a result of any other situation, right? So that's why the patient should be encouraged to describe the symptoms spontaneously. We all know about it. We don't have to give suggestions, talk instead of the patient or infer the information. Initial questions should be open-ended and as general as possible. So we have to open the door, open the possibility to talk about the situation to the patient without interrupting, taking time, without being so aggressive or without sounding offensive. Follow up with more specific questions if needed, but avoid putting words in the patient's mouth. That's why I don't give any suggestion about it. Patients know how to do it. Patients have the chance to make it, and they need to get in confidence because you as a doctor are a stranger to the patient. Okay, it's not easy to talk about a health problem because in the human situation, the human beings wants to show that they are strong enough for living. But when you go to the doctor, when you go in pain or for another situation, you feel different, you feel sensitive, you feel that you are not enough at this moment because your situation could be considered a trouble. That's why giving the open-ended questions, we give the chance to get in confidence, and according to that confidence, it's possible to make it work in a properly way. An example of open-ended question: what is your appetite like, for example? When saying what, the patient has the chance to think about it for a minute maybe, and then tell us the information. They have the chance to tell us in their own words and expressions the answer in the best way the patient can. Or maybe another way: how is your vision? Just another example. We are giving the chance to the patient to describe the situation in order with their own words, about the experience the patient has about it. And it's possible to understand, while listening to the patient, how this situation is affecting him at this point. About closed questions, well, we are only expecting an answer, yes or no, right? For example, have you eaten today? Yes, I have. Enough. So it's not the way we expect to work. Or maybe, is your vision ever blurry? Yes, it is, or no, it isn't, right? And that's enough, because we are giving the patient the description that he or she should tell us. So just for taking into account. As an example, we have the central nervous system for making a few questions. Okay, for example, do you suffer from headaches? Very common, right? Have you ever had a blackout? What about fits? Have you had any dizziness? Do you get ringing in the ears? Have you ever experienced any numbness or tingling in your hands or feet? Do you have any problems sleeping? As you can see, all of these questions are related to the system. We all had the chance to make all of them, but they are just suggestions. If you have more, use them the most you can. Talking about patients' ideas, concerns, and expectations, well, sometimes we are not used to do this. In Latin America, well, it's according to the doctor you are talking about, because it's ruled that we should talk to the patient and relatives about the prognosis, how the situation is going on. Why we have to do it? Because we have to clarify the situation that is happening with the patient. We have to be we have to ensure that they, as relatives, understand how these changes are going on. That's why it's important during the consultation to give the patients the chance to express their own ideas and concerns about the problem and to determine what their expectations are. Okay? What the expectations, what they are waiting for this situation, what they are waiting from us. So according to that, it's possible to get in touch, to get in confidence, to break the ice. And we can understand how the patient is feeling, and we can really bring some comfort. We have these acronyms, ICE, ideas, concerns, and expectations. This is a way of remembering this important activity, we can say. Typical questions about ideas, for example. What do you know about this problem, condition, illness, or disease? What do you certainly know? What kind of information did you collect about it? Because when patients receive a diagnosis, usually they try to understand what is going on, and they make an investigation. They make a research. And according to the information they collect, they can come nervous with anxiety, or they can come back while being so clear how the situation is going on, and what about the prognosis and treatment and everything, because they are well informed. Never ask Dr. Google. That's the first advice we give as doctors, because everything is cancer. So take it in account. Another question, do you have any ideas about it? Sometimes patients have no idea what we are talking about. And they just say yes because they feel nervous. They feel like doctors can become upset because he is a doctor, and it's not possible to show this situation. We have to clarify the doubts or the confusion with some other ideas in order to give that peace to the patient, that we are doing the best we can, and we are following a protocol of actions. Another question, how do you think you got this problem? When we talk about an infectious disease, we have to be clear and clarify, and if it's possible, identify the way of acquiring some conditions. In that way, it's possible to get the patient confidence, and it's possible to make it properly. Another question, what do you mean by? So this question is so clear because we are giving the chance to the patient to explain us what they understood. And if they made it wrong, we have to correct that ideas, okay? Talking about concerns, we have the chance to do it, to make these questions. What are your worries about it or about this condition? Worries, always we have the problem of asking about it because all the worries sound like an alert to the patient. And these worries usually make patients misunderstood the information and make mistakes. That's why to talk about worries at this point with me could be the best way to make the family, to make the patient and relatives understand that with treatment on time, everything is going to be great. Another question, how might this affect in the rest of your family? How it could be wrong, how these changes are gonna be, would be considered as a trouble from you and the patient. Okay, so take it in account. While talking about the rest of the family, patients get relaxed, consider that certainly you are interested in the situation, not just in the patient, not just in the medical information, just, well, you're interested on the person that is suffering this. Families, of course, are important, relatives, maybe siblings, maybe children. Sometimes patients ask to the doctor to talk with the family because patients don't know how to express these ideas. They need some help, some extra help, right? About expectations. What do you think will happen? It's a very common question when we talk about diseases or when we talk about complicated conditions with relatives. In COVID-19, during the pandemic times, that was one of the worst questions to make to the relatives and the patient. What do you think would happen if we don't use the mechanical ventilation? What do you think will happen if we don't use that part of the medication, for example? So you know, it's not easy. Not easy to understand, not easy to support this question and to give a correct answer. Just listen to the patient, organize the idea, and correct it in the detail that they need. Another question, what do you expect from me? Certainly, when we make this question, we are showing the patient that we are humans too. We don't have extra powers. We are not gods. We are just doctors. We are helping the body to recover, but we don't have the magic to change the situation because of yes, without any support. We are making science, yes, but we are applying all the years of research that a previous colleague made. Okay, I think it's so important to clarify, what do you expect from me? What do you really expect from this treatment? What do you expect from this hospital, for example? Another question, what were you hoping we could do for you? It's so hard to understand, so hard to answer. What do you expect? What do you really want? What do you certainly need us to make for you? So, you know, it's not easy to ask or to make these questions, but they are necessary. And we have to recognize that sometimes we cannot do it all of this by ourselves. We need extra help. This chart is very important. There are the phrasal verbs in history taking. Why they are so useful? Because using phrasal verbs, we can go through the context. We can show that our patient is talking about. We can not make a resume. We can go to the point without rounding too much on this information. So we have to be clear that the several meanings of a phrasal verb, it's a benefit for us. Okay, for example, the phrasal verb bring on. Is there anything special that brings on the pain? I mean, is that anything special that causes, that induces the pain? Easy to make, right? It's just with practice to memorize all of them and to memorize the meanings in the way of using this. For example, come on. When does the pain come on? I mean, when does the pain start? When does the pain commence? So take it account. Or another way, put on. I put on a lot of weight in the last month or so. Another way to say it, I've gained weight, or I gained a lot of weight in the last month or so. Just practicing while reading, while talking, it's possible to memorize lots of them. The list is just a small example how to do or how to use them, but it's very clear in order to catch and understand the meanings of that situations. And remember this, your eye cannot see anything that your brain doesn't know. Okay, if the brain is without information, eyes are not enough at this point. Eyes are not going to recognize the situations. So this was the presentation. It was the material for today. So keep on reading, keep on practicing. Please start feeling the pull. I'm sending it. And as always, send me a message to the chat in order to realize you feel the pull, okay? I'm going to share the information, the slides to the chat, and you can download it, okay? Let me open the file. Okay, give me a minute to send it again, Andrea. Okay, the PDF file with the presentation is in the chat. Please let me. Okay, perfect. You corrected, Andrea. Thank you. So let me know when you download it. And if there's no way to download the presentation, don't worry about it. I need one. student more 19. Okay, all of you fill the pool, right? I need to take attendance. Patience.
Thank you,
Oh,
teacher. Bye.
okay, bye. Thanks for your attendance and see you tomorrow in the workshop. Okay. Let me see. Thank you, teacher. Thank you. Thanks to you. Okay, I'm closing everything. Okay, Aniel, can you hear me?
Yes.
Okay, perfect. Did you fill the pool? Did you have the chance to send the answer?
Yes.
Perfect. Was possible to download,
See you
right?
tomorrow.
See you. Have a great night.
Thank you. Bye-bye.
Bye-bye. Okay, everything.